Hello, everyone. Welcome to the second session that the Health Law Practice Group at Fasken Martin Dumoulin is holding on developments relating to COVID-19 applicable to Ontario's health law sector. My name is Lynne Golding, and I am the head of the Health Law Practice Group. Some of you will have joined us about 2 weeks ago when we spoke about the first emergency orders that were issued that pertain to healthcare. It is amazing, everything that can occur over a 2-week period. Our landscape has changed quite a bit. We now know that the front lines, if you will, the battle lines in this COVID-19 battle in Ontario are in the long-term care homes we have here. And so our seminar today, while we'll be speaking to all healthcare providers, we're going to focus a great deal on the long-term care homes and the orders that have just been announced in the past day or so pertaining to them. So today I am joined by 3 of my partners. The first is Brian O'Byrne. Brian will be familiar to many of you. Brian has practiced employment and labor law in the health sector for over 30 years. He's worked for probably at least half of the hospitals in Ontario. And then we'll also be joined by Erin Porter. So Erin Porter is also a labor and employment lawyer. She has a great deal of experience working practically in the long-term care home sector, as well as being a very trusted advisor to it. And then finally, we will also hear from Laurie Turner, another one of our partners who works in the corporate area, and she will be speaking to the orders and regulations that pertain to the healthcare sector, the new orders and regulations that are not specifically related to employment and labor matters. So because of the new developments that just came out yesterday, we are going to reverse a bit of the order for this seminar. So we had thought that what Brian would be speaking about would be less important than Erin's. Oh, I don't want to say one is more important than another, but more timely. But that turns out to be a bit different. So we're going to skip ahead in these slides and go directly to Brian's portion, and then we'll come back to Erin's. So fasten your seatbelts while I fast forward through these slides.
Thank you. Good morning, everybody, and welcome to today's webinar. You'll recall, as Lynn said, that we had another webinar about 2 weeks ago, and we talked about the different orders that had been issued by the government at that time. Affecting primarily hospitals, but also to a certain extent long-term care homes. There have been a number of developments since our webinar 2 weeks ago, and I would say that primarily the new developments have basically involved long-term care homes, because as Lynn said, that's where the center of the crisis is right now. Hospitals have had some new orders and directives that impact them, but not as much as long-term care homes. And so what I will do is briefly touch upon the new developments affecting hospitals, and then Erin will tell you all about the developments with respect to long-term care homes. The first new development is what the government called their COVID-19 action plan that was announced by the Premier yesterday. And there are 3 goals that he pointed out that this new action plan has. The first is aggressive testing, screening, and surveillance. Secondly is managing outbreaks and the spread of the disease. And third is what he called growing our heroic long-term care workforce. And we've heard that a number of long-term care homes are overburdened and are having difficulty getting staff. And so one of the things that the Premier has said he's going to do as part of his COVID-19 action plan is provide for redeployment of healthcare workers from areas in the healthcare sector that are experiencing fewer patient volumes, such as certain hospitals, and redeploy those people into long-term care homes. And we're probably talking about registered nurses, registered practical nurses, PSWs, and perhaps others. And we haven't gotten the details on this yet. The Premier said yesterday that it'll be 24 to 48 hours before we find out all these details, but that is something that is obviously going to impact certain hospitals. Some of their staff may very well be tapped to go over to a long-term care home. And I'm sure that when the government has finalized the wording for their order, and it'll likely be an order, it'll probably again make it clear that this overrides the provisions of any collective agreement. Because of course, in the absence of something like this, an employer couldn't just say to a bunch of its nurses or other employees, you have to go over and work at such and such a nursing home for the next 2 weeks. So we'll wait to see what the new order will be there. The second area, and Lynne, if you could go to page 8, the second order that I want to talk about that impacts hospitals is you may have heard that hospitals have been sending some of their patients over to retirement homes, either for a temporary basis or on a short-term basis, basically to ease the burdens at the hospital, and in some instances to keep vulnerable patients who are not suffering COVID-19, to keep them away from patients who are suffering from COVID-19 infected patients. The government has indicated that yes, hospitals, you can do that. And the concern then was probably more a concern on the part of the retirement homes. If we end up taking these patients from the hospitals, does that then make us covered by the Hospital Labor Disputes Arbitration Act in terms of our operations? Now, as we know, a number of retirement homes voluntarily are covered by HILDA. Some, there have been rulings that they're covered by HILDA, but there's some out there who haven't addressed that issue yet. And what the order, Ontario Regulation 140/20 makes clear is that if a hospital does in fact send patients on a temporary or short-term basis to a nursing home, that shall not impact whether or not the Hospital Labor Disputes Arbitration Act applies to that particular nursing home. Secondly, that act of sending patients to the retirement home will not impact a question as to whether by doing that, the retirement home and the hospital are a common or related employer for labor relations purposes. And finally, the regulation also states that the mere fact that you sent these patients over there does not constitute a sale of business or sale of part of a business under the Labor Relations Act, because of course that would impact bargaining rights of unions. If you go to page 12, Lynne. The third area where hospitals are impacted is the new regulation that came down 2 days ago on the 14th, the evening of the 14th. And this is the one that's received a lot of attention, and it deals with long-term care home employees not being allowed to work anywhere else, either at a different long-term care home or at a retirement home or at a hospital. So I'm talking about this, Erin will have a lot more to say about this, but I'm talking about it because it could impact and likely will impact hospitals, because there are a number of hospital employees who work both at hospitals and at long-term care homes. And what the regulation says is that starting next Wednesday at 1 minute after midnight, an employee of a long-term care home who performs work in the long-term care home cannot also perform work at any other long-term care home or at a hospital or at a retirement home. So they essentially have to make a choice. If you're working at both places right now, you can continue to do so till next Wednesday. But after that time, you're going to have to make a choice. If you choose to stay at the long-term care home, then you're not going to be able to work at a hospital. If you choose to work at a hospital, then that's where you're going to be for the next while. And there is a section in the Act that says that as soon as reasonably possible, and in any event, no later than this Friday at 5 p.m., any person to whom this section applies, and that means if you're an employee who works at both a hospital and a long-term care home, you have an obligation to inform each of your employers that you are working at another establishment. So that in my case here, if we're talking about hospitals, the hospital will then know that you're working at a nursing home. And if they see that you then show up at work at the hospital, they're going to say, what are you doing here? And the person will either say, because I've given up my job at the long-term care home, or if they say that they haven't, then the hospital will have to enforce the situation. And finally, if we go to the next page, Lynn, is Directive number 5 that came out about a week ago. And this is a directive that applies not only to hospitals, but also to long-term care homes. And basically, this directive focuses on a couple of different things. First is there must be a point of care risk assessment conducted before every patient interaction. And I think that's very, very important because obviously the results of that assessment will determine what PPE you may or may not require. There's also provisions in there that hospitals, as well as long-term care homes, have an obligation, they put it, to engage in the conservation and stewardship of personal protective equipment. And hospitals are required to provide all their healthcare workers with information on the safe utilization of PPE, and there must be training on how to use PPE. Hospitals must keep their employees and their unions apprised of how they're doing in terms of stockpiling and the amount of equipment on hand, so that steps can be taken if necessary to deal with the situation. And I think those are the main aspects covered by this particular directive. There are certain specific ones that apply to long-term care homes, and Erin will speak to those. But sorry, there is one other one that I think is significant, and that is that all healthcare workers who come within 2 meters of a presumed or confirmed COVID-19 patient must have appropriate PPE, and that includes an N95 mask and gloves and other protective equipment. So the government is really essentially ramping up all their regulations and directives to do the best they can to ensure that the frontline workers keep safe. So those are the main provisions then that apply to hospitals and have come about since our last session. So over to Erin.
Thank you, Brian. All right, going to go back up to the top. Erin, take it away.
Thank you, Lynn, and thanks, Brian. And before I get started, I did just want to take a moment to thank those who are currently working in the long-term care, retirement, and healthcare sectors. I know these are difficult and trying jobs at the best of times, and these certainly aren't the best of times. So we appreciate the heroic measures that are being undertaken right now. Lynn, if you could just proceed to the next slide, please. Thank you. So as Brian mentioned, the Ontario government released an announcement yesterday, or made an announcement yesterday, talking about an action plan, a COVID-19 action plan, specifically targeted at long-term care. And that's in recognition of the fact that almost 50% of new cases of COVID in Ontario each day are coming out of the long-term care system. And so the government has recognized that this really is the epicenter of the crisis. And I think that previously they had been planning and expecting that hospitals would be the ones most significantly impacted. But what they're actually seeing in practice is that that long-term care homes have been very hard hit by this pandemic. And currently, I think it is remarkable and worth noting that there are almost 626 long-term care homes in the province, and about 115 of them have currently announced that they're in outbreak. And so certainly we don't want to see any homes that would be an outbreak or have confirmed cases of COVID. But I think the fact that this number is relatively small compared to the number of long-term care homes is a testament to all of the work that is currently being done in the industry to try and prevent the spread of this disease. And so as part of the announcement, Lynne, if you could just go to the next slide. The Premier focused on a couple of things. He talked about the $243 million that is going to be put into long-term care. He, as well as the Minister of Health, also made several statements saying that they would spare no expense. So the expectation is that there may be more funding announcements or targeted funding announcements that may specifically address certain concerns, such as infection control and things of that nature. The Premier also said that there is capacity right now in the healthcare sector, that hospitals are seeing that they have staff that are being underutilized, and so these staff will be redeployed to long-term care. I know we've had a question come in asking about whether or not this will revolve around just the public system or if private providers could also be impacted. We don't know yet because this is constantly changing. Every day there's a new announcement. So we don't know yet exactly what the redeployment strategy will look like. What we can anticipate from the comments being made and from the information that has been released is that this is going to be universal, so that it will not just impact publicly funded or public hospitals or municipal long-term care homes. He also talked about enhanced testing. So currently, right now, the hope is that there will be 8,000 tests performed in the province each day. And right now, the report seemed to indicate that we're under that. And Premier Ford has talked about doubling that, so going up to almost 15,000 tests a day. And that would be targeted at those in the long-term care sector. He talked about infection control specialists that are being deployed to the homes. That new PPE is going to be delivered. You can call a hotline, and it apparently is going to be delivered within 24 hours. He said that it may take longer for some providers who are in rural areas. And he has made a personal commitment that if you call him and say that this isn't happening, because I know a lot of long-term care homes are still saying that they're not getting the PPE that they need, that he's personally going to look into it. So there seems to be at least a commitment there that people will have the PPE that they need. He also talked about the potential for top-up on pay for long-term care workers and essential healthcare workers. And this echoes what the Prime Minister has said. I think that the feeling is that if people can collect $2,000 on CERB for not working, then they want to ensure that people who are working, and if they only are working part-time hours, that they may be entitled to benefits that would entice them to stay and to do this incredibly important work at this time. And in his announcement, he talked about the order of limiting workers to a single site. And so Ontario is following British Columbia and Alberta, and I believe Newfoundland has also now introduced these single site requirements. And that's the regulation that Brian was talking about. Currently, that regulation only applies to long-term care. Retirement homes, we've seen that often the same regulations will come out or will be encompassed in an updated directive, but currently this does not apply to the retirement home industry, just to long-term care. Lynne, if you could forward to the next slide, please. So as Brian mentioned, the COVID action plan has 3 goals. The aggressive testing, screening, and surveillance, managing outbreaks and the spread of the disease, and growing our heroic long-term care workforce. So they have provided some details on their website that gives a little bit more information about each of these items. And we'll expect that within the coming days that the information will be expanded. Lynn, could you go to the next slide? So another thing that I wanted to speak about, Brian spoke about Directive 5, and I wanted to speak about Directive 3. So as you are no doubt aware, this directive has been updated several times since the pandemic was announced, and the last update was on April 8th. And so in this update, a lot of the previous items remain unchanged. So the requirements that are set out in that directive are still there. And although the directive stipulates that it's for long-term care homes in the title, and it's the directives made under the Long-Term Care Home Act, they also do apply to retirement homes as well. So retirement homes are going to want to ensure that they're following all of the information that is outlined in these directives. There are a couple, so I've put on the screen, both on this slide and then on the next slide, the information that is covered in this directive. There are a couple of ones that are new that had not been in the previous directive that I did just want to highlight to make sure that people are aware of. So one of them is about staff masking. And so it states that long-term care homes and also retirement homes must immediately implement that all staff and essential visitors wear surgical procedure masks at all times during the duration of their full shift or visits in a long-term care home or retirement home. And so this is required regardless of whether or not the home is in outbreak. So even if you don't have a single reported case of COVID-19 in your home, there is still a requirement that staff and essential visitors are wearing these procedural masks throughout their shift. During breaks, staff are to remove the mask, but they still have to then practice social distancing of 2 meters to ensure that there isn't staff-to-staff spread. So that is a new requirement. There is also a new requirement around triggering the outbreak assessment. And so this talks about what must happen if one resident or one staff member has presented with new symptoms that are compatible with COVID-19. And so it outlines the different steps that you have to take. And of course, now we know that even one case of either a staff or a resident at a home would put that home into outbreak. And so they would have measures that they have to follow as a result of that. So those are the new measures under Directive number 3. They're updating the testing requirements and testing protocol quite frequently. So we would encourage you to make sure that you're also staying on top of those obligations as well. Lynn, can you progress for me? And one more, please. Great. And so then we get into the final thing that I was going to talk about today. And Brian had talked about this already in his part, the agreement between health service providers and retirement homes. So this has now been put out in a regulation, and it's nice to see that they are, as they have with the other regulations, recognizing that there could be labor implications to any of these measures that they're taking. And they really are taking a very strong approach in this and saying that things like HILDA or the sale of business provisions under the Labor Relations Act won't apply. And by stating that the sale of business provisions won't apply, then they are in essence also stating that Placerta wouldn't apply, so you don't have to worry about any long-term detrimental impact that may occur if you're following these regulations. The government has put out a document about guidelines for the use of retirement homes. And the document also covers hotels, but for the purposes of this, we'll talk about the retirement homes. And so they put out a document that outlines sort of the parameters behind what this type of a relationship would look like. And so considerations for how retirement homes can get onto the list if they're interested in participating in this program. Okay, and I think, Lynne, do you want to progress to the next? And then the last thing that I'll talk about are the long-term care emergency orders. And so this is Regulation 9520. And this was out, had been announced, but was not enacted at the time of the last seminar or webinar. So there was some discussion around it then, but since that time it has been enacted and is now in force. And so this, of course, expands the powers available to long-term care homes to manage their response to COVID-19. And it's interesting that it talks about taking any reasonably necessary measures in order to prevent and alleviate the spread of COVID. Because some providers are taking steps over and above what has been set out by the government. And certainly some providers were doing things before the government enacted legislation supporting that. For example, some providers were already having a single site employer policy in place. And really, this is the regulation where you would justify those actions and state that you were doing this in order to take a reasonably necessary step in order to ensure that you were trying to prevent the spread of COVID-19. And so some of the things that were talked about in this regulation are outlined on the next slide. So Lynne, if you could advance for me. Thank you. So it talked about increased flexibility in certain areas, so reporting, documentation. They recognized that a great deal of time for healthcare workers was being and is being spent on documentation. That's typical for all healthcare workers, particularly those in long-term care. So they really reduced some of the daily requirements for documentation. They changed things around staffing. So for example, what kind of orientation and training you had to do, the requirement to have a registered nurse on site 24 hours a day, 7 days a week. They also have put in place certain provisions around relaxing the requirement for a vulnerable sector search if you're hiring new staff. Lynne, could you just advance one more, please? Oh, and that's it. So, and then there are other provisions in there as well that they have taken this opportunity to relax, recognizing that a great deal of time really needs to be spent on trying to ensure that homes either don't have any outbreak, or that if they are an outbreak, that they're able to focus all attention on trying to manage that and put in place the added requirements for things like active screening and cohorting of staff and residents. So they're trying to recognize that those requirements are going to take up a tremendous amount of time and try and ease the burden on the other side. Thanks, and now I will turn it over to Laurie once Lynne jumps ahead to the right spot in the slide deck.
Great, thank you, Erin. So today I have a little bit of a mixed bag. As Lynne mentioned, I'm going to be summarizing orders, legislative changes, and other developments that, while all related to COVID-19, fall outside of the realm of labor, employment, and human resources, and therefore were not addressed by Brian and Erin earlier. Just flip next slide, please. Great. So 2 days ago, on April 14th, the government announced that on the advice of the province's chief medical officer, that the declaration of emergency in Ontario, which was made pursuant to the Emergency Management and Civil Protection Act, was extended for a further period of 28 days until May 12th. So what this extension does is that it permits the province to continue to enforce the existing emergency orders related to COVID-19, such as those related to the caps on the number of people in public gatherings, and also with respect to hospitals, which were discussed in our last webinar. And then in addition to continue to make orders pursuant to the EMPCA where the specified conditions are met. Next slide, please. Great, thank you. So Ontario Regulation 120/20, made under the Emergency Management and Civil Protection Act, was made on April 3rd. And pursuant to this regulation, police, firefighters, and paramedics are authorized to make requests for the disclosure of COVID-19 status information about an individual that they interact with in the course of their duties. So this request can be made to what are called specified custodians, which is defined by the regulation to mean first laboratories and second medical officers of health, being a medical officer of a board of health within the meaning of the Health Promotion and Protection Act. So a little bit more detail, more specifically, this regulation provides that on the request of a paramedic, a firefighter, or police officer, a lab or a medical officer of health shall take all reasonable steps to ensure that any COVID-19 related status information that is within its custody or control is disclosed to the requester within a timely manner. So with respect to the flow of information or the requested information, so the information can flow directly from the lab or the medical officer of health, as the case may be, to the requester, or if the ministry develops a system to facilitate access to this information, then it can be an indirect flow, so an indirect disclosure via the ministry to the paramedic, firefighter, or police officer, whoever the requester is. There are two important limitations. So first, as mentioned, it applies to COVID-19 related status information, and that is limited to the name, address, date of birth, and whether or not the individual has tested positive for COVID-19. So it's not just a blank statement to say that they can have whatever information they want. It's just specific to that information. And second, the ability to access this information will cease when the order ceases, which is upon the state of emergency ending in the province. This order also gives the Ministry of Health the ability to collect this COVID-19 status information, and then also, importantly, to use and disclose this information to paramedics, firefighters, and police officers, as I just mentioned. And they're able to either collect the information or use and disclose this information, one, where it's done in accordance with the order, or two, where they deem it to be necessary to prevent or respond to the effects of the emergency in the province caused by COVID-19. Go to the next slide, please. Great. So on April 1st, the government announced that the transfer order to move the Ontario Telemedicine Network into Ontario Health, which was issued on March 18th of this year, would come into effect. So just as a brief reminder, pursuant to the Connecting Care Act, the Minister of Health was given the authority to, among other things, transfer specified organizations, including Ontario Telemedicine Network, to the agency, being Ontario Health. The announcement also confirmed an earlier announcement of the province that the work locations and also the reporting obligations of OTN will remain the same at this time. So in making this transfer announcement, the government had stated that this transfer will further help pave the way for its digital-first approaches to healthcare in the province, including virtual care, which we all know is important during COVID-19 pandemic. And finally, in its announcement, the government had indicated that based on guidance received from Ontario Health, the transfer of health system funding, planning, and coordination functions of the local health system local health integration networks, or LHINs, will be postponed while the province continues to actively respond to COVID-19. And so the transfer of those functions of the Lynne to Ontario Health will be done at a later date. If you can advance the slides, please. Great. So the next slides, the next two slides actually deal with changes affecting what are called private label products. And these are products which are acquired by a pharmacy from a manufacturer that first did not fabricate the product itself, and second, is not at arm's length to the pharmacy. So there's a lot of terms here, and it's a little bit complicated, so I'm just going to provide you up front with a summary of what, in effect, these changes actually do. So first, these changes make private label products eligible for funding under the Ontario Drug Benefit Program. And second, they make it easier for pharmacies to sell these private label products to private and cash-paying clients. And so going back a little bit in terms of background, private label products, or PLPs, have since 2010 been barred in the province from being listed on the Ontario Drug Benefit Program formulary, or being designated as interchangeable under the Drug Interchangeability and Dispensing Fee Act, or DIDFA. And the purpose of those prohibitions was to prevent pharmacies from purchasing fabricated products at a lower price than the amount that was going to be reimbursed from the Ontario government without passing on such change or on such savings to the Ontario government or to private payers. So at this time, or sorry, rather back in 2019, at the end of 2019, as part of its Open for Business or Red Tape Reduction initiative, amendments were introduced to remove these prohibitions, with such amendments to take effect on July 1st of this year. However, in response to concerns raised by pharmaceutical manufacturers and retailers about possible disruptions in the pharmaceutical supply chain, and also to offset the possibility of drug shortages, the government decided to move up these amendments to, or the effective date of these amendments, from July 1st to April 1st. So you can just skip to the next slide. Thanks. Oh, sorry, just back one slide. Thanks. So on this slide, I'm just gonna speak to this briefly. So the two regulations here, OREG 12520 and OREG 12420, are just the amendments that were made to existing regulation to give effect to the changes that I just spoke to. So the changes to the Ontario Drug Benefit Program Act, and then DIDFA as well. Okay. So next I'm going to speak to some changes that were made to regulations under the Pharmacy Act. So effective on April 17th, Regulation 12620 was filed, which amended the general regulation under the Pharmacy Act. And the amendment removes a restriction on pharmacists, interns, or registered pharmacy students from adapting or renewing a prescription for a controlled substance under the Controlled Drugs and Substances Act. And the amendment, or the lifting of the aforementioned restriction, only applies first during the period of time in which the quote-unquote coronavirus exemption, which was issued by Canada's Minister of Health under the Controlled Drugs and Substances Act on March 19th, is in effect. So it's only for a time limit. And second, only to the extent that the coronavirus exemption or the Controlled Drugs and Substances Act authorizes a member to adapt or renew such prescriptions. So just speaking briefly to what that coronavirus exemption was that I referred to. So that exemption was introduced by Health Canada as a means to help maintain Canadians' access to controlled substances for medical treatment, such as opioids, during the COVID-19 pandemic. The amendment also provides a method for pharmacists to verify the existence and also the details of a prescription that they are asked to adapt or renew. So essentially during the period of time that this coronavirus exemption is in effect, pharmacists are permitted to verify the details or the existence of a prescription for these products that they are being asked to adapt or renew through expanded means, such as by reviewing a photograph or a fax of the prescription rather than receiving an original from the pharmacy. Just jump to the next slide. So this slide was addressed by Brian earlier, so I'm going to skip this slide in the interest of time and move on to the next. So on April 10th, the government announced the next phase of its strategy to expand COVID-19 testing. So in announcing its expanded strategy, the government stated that its strategy follows extensive efforts that it has been making to expand Ontario's testing capacity for COVID-19. So in addition to the current level of testing to the public at the existing 100 assessment centers which have now been established, the government will proactively test several priority groups and otherwise step up testing in respect of these priority groups. And those priority groups include hospital inpatients, residents in long-term care homes and retirement residences, healthcare workers, caregivers, healthcare providers, and also paramedics. In making this announcement, the government has stated that it will expand its testing by leveraging hospital communities and research laboratories. Great. If you can advance to the next slide, please. Great. So on April 7th, the government made a further announcement as part of its action plan to stop and respond to COVID-19. It said that it was taking additional steps to recruit healthcare workers to increase the capacity of staff in facilities that are hardest hit by COVID-19, including hospitals and assessment centers and clinics. The government announced a new online tool to support this initiative called Health Workforce Portal. And the purpose of that is to match frontline workers with employers who are in need of support. The frontline workers that are being targeted or identified as being candidates include non-active healthcare workers, so people who have been trained in healthcare but are working in other fields, retired healthcare workers, and internationally educated professionals. Move to the next slide, thanks. Okay, so then finally, I'm going to speak to on March 27th, Schedule 37 of Bill 138, which was introduced by the Minister of Finance in November of 2019, came into force. And that enacted the Supply Chain Management Act, or Government Broader Public Sector and Health Sector Entities Act. So among other things, the Act will enable the Lieutenant Governor and Council to create regulations that prescribe rules for supply chain management for government agencies, broader public sector agents or entities, and also health sector entities. And this act was introduced as part of the government's policy of centralizing the province's procurement activities. And notably, while the act was proclaimed into force at that date, and also 2 regulations under the act have also been introduced, it's a bit of anticlimactic as the substance of the rules for the supply chain management, vendor performance standards, and also the reporting obligations are to be set by the Lieutenant Governor and Council through regulations which have not yet been introduced. So accordingly, while the bones of the changes have come into force by way of the Act, we are still waiting for the regulations to put some meat on those bones so that the changes and the effects of this legislation will become clear. So then I'll turn it back to Lynne for the Q&A.
Thank you, everyone. Really appreciate those presentations, Erin, Brian, and Laurie. So we're now going to open the session to questions. We did have some questions submitted ahead of time, so we will start with those. The first question was, What documentation is required to minimize potential liability for staff, client illness, etc., due to COVID-19? That is screening of staff, client, self-isolation, PPE. Erin, would you mind responding to that, please?
Sure, thanks, Lynn. So I think that there are a couple of areas that you should look when you're thinking about what documentation is needed. So the first one, again, I would encourage you to go back to Directive 3 and look to see what is in there. So for example, there is a requirement for active screening of all staff twice a day, and for all residents twice a day as well, or at least twice daily. So I would make sure that you have documentation confirming that you have participated in that active screening and that you're maintaining that so that you can demonstrate that you're in compliance with the requirements that have been set out in the directive. And then it also, I would look to the regulation that limits the documentation requirements under the Long-Term Care Act. And so there it talks about documentation, and it says licensees are not required to document information unless it involves an incident of significant nature or is required to ensure the proper care and safety of a resident. So you still want to make sure that your staff are putting things into the progress notes that would be of a significant nature, and that you do have your incident reports, critical incident reports, and documentation that you would normally complete in a circumstance like that is still done. So not to take a hiatus from all documentation altogether. So those are the ones that jump out for me, really, the requirements under active screening of both staff, visitors, and residents, and then also looking back to what the regulations say about documenting critical incidents.
Thanks, Erin. The next question was this: emergency orders and the relationship to the Public Hospitals Act. Does an emergency order supersede restrictions within the Act? Laurie, do you want to answer that one?
Sure. I think that the simple answer is yes. So the content of these orders does supersede any of the restrictions that are included in the Public Hospitals Act.
Thanks, Laurie. I'll have you answer the next one as well, which is, what is the impact of the rules and regulations and orders that we've been talking about? What is their impact on non-urgent testing within independent health facilities?
So our understanding is that testing within independent health facilities is continuing, subject to proper screening procedures taking place. So I know that the Ministry of Health published some guidelines to independent health facilities in March regarding COVID-19, and included in that guidance was a particular emphasis on screening. So if anybody wants a copy of that guidance document, we're happy to provide that.
Thank you, Laurie. The next question has to do with the ICU Treatment Triage. And the question is, what does that, how does that affect the liability of physicians? So the question relates to a document that I think has been referred to as a critical care triage document. It's a very detailed document which sets out how limited resources would be allocated, access to ventilators, et cetera, in hospitals if there are not sufficient number of ventilated beds for all who require it. It's a very thoughtful, thorough, and ethical document that's been prepared. It's been prepared for a number of reasons, including, of course, to ease the decision-making that will have to be made at a point of crisis, so that the triage system is already identified. The beds will be determined based on who is deemed to be the most needy. So a large part of the reason for the creation of the document, as I understand it, is obviously to facilitate those processes, but I understand that it has also been developed to limit physician liability for the decisions they will have to make about who has access to those limited resources. The thinking being that if a physician acts in accordance with that triage program, the physician is meeting the professional standard that they are required to meet. I know that there was a a lot of input into the development of that document. Now, I have to caution you, I am not a litigator, and I don't do medical malpractice myself, but this is what I understand to be the thinking behind the creation of that document. So we'll now go to the questions that have been submitted. And Andrew, I'm just looking for how I get those. Oh, here we go. Thank you. So the first one is the redeployment measures only apply to workers, questions do the redeployment measures only apply to workers in the public system, or does it also apply to individuals employed by private sector employers? So Erin, I think you spoke to that. Do you want to pick this up?
Yeah, thanks, Lynn. And so right now, the redeployment measures, other than an announcement that it's coming, we don't have too much information about it. On the website, when they're talking about the action plan, they talk about just healthcare workers from areas in the healthcare sector. So what I would expect is that it won't just be limited to those in the public sector, but that it will apply more broadly.
Thank you. I'll read this question, and I'm not sure, I think all three of you maybe have a view on it. Does Ontario Regulation 1/2020 permit police officers, paramedics, firefighters to mandate testing to determine COVID-19 status?
My view is that it doesn't give them the ability to mandate testing. So I know that the order specifically provides that laboratories and medical officers of health only have to give the information that's in their custody or control. So I would think that if the information isn't within their custody or control, they don't have any responsibility to undertake additional testing in order to respond to a request.
Yes, I think that's right. I don't think there's any mandate for that. Thank you, Laurie. We have a comment more than a question. I think it's a very good comment. I'll just read that out. We provide supportive housing as a not-for-profit community agency, and we seem to have been forgotten as we're a small agency and there's a lack of PPE. It's a big issue for them. They're not designated as long-term care home or retirement home, so they're not making the headlines in related to these matters these days. So thank you for that observation, and hopefully with more PPE coming into the province, we'll see greater allocation of it.
Sorry, Lynn, if I could just jump in, it's Erin, if I could jump in on that. I know that when Premier Ford was making his announcement yesterday, that question was raised, or a similar question was raised by a reporter about group homes. And the same feelings are being expressed by those in that community as well. And so the Premier said that he was considering that to be a priority as well, and that he encouraged people to reach out to his office directly if they are in that circumstance and they're not getting the PPE, and he would put them on the 24-hour list so that they should be getting it. So I'm not sure if it's true or if he's just being a politician and saying that he's going to solve the problem. But certainly when pressed on that yesterday, he was saying that you should also be getting PPE within 24 hours. So if you haven't done so already, I would really encourage you to reach out to the Premier's office to see if you can get the supplies that you need.
I was also just going to say too that I know with respect to the expanded testing that they've specifically listed individuals living within or individuals working within congregate housing situations as those within the targeted population for the increased or expanded testing as well.
That is really helpful. Thank you, both of you. Another question, if a hospital is collecting but not resulting, would the hospital still be responsible for disclosure to first responders? Not sure what is intended by that. Anybody understand that question? The hospital is collecting the information, but COVID is not resulting. Would the hospital still be responsible for disclosure to first responders? I guess that's it, Laurie.
Yeah, I'm not sure I really understand.
Well, I wonder if it goes back to the regulation that you were speaking about before, Laurie, where paramedics and police officers can be provided with information. So if a hospital is asked for that information, does a hospital have to give it, or is it just laboratories that have to provide the results of a COVID test?
Yeah, so within the specified custodians that were named in that, it was just limited to laboratories and also the public officers of health. That may be because there's not already a permittance under PHIPAA for those laboratories or those chief medical officers of health to be disclosing that information directly to paramedics. So it might be just responding to that gap in particular, but I'm happy to. I'm not sure we understand the question fully, so I'm not sure if we've responded to it, but we're happy to take it offline if somebody wants to email us directly about that.
Thank you. In the stepped up testing, priority groups include caregivers. What definition is the government using here? That could be a significant number of community members who care for older adults. Erin or Brian?
I think I might just jump in here. That's okay. Yeah, so I think that in the announcement, the number of groups that were identified as being kind of on this target list, or the groups that were being targeted, was actually quite broad. And as you said, or as the comment had said, it refers just generally to caregivers and also to what are called just generally care providers. I looked through the announcement that was made, and there wasn't really any further details about who specifically would fall within those groups. So I think that is probably just up to interpretation, but I think given that it refers to both, care providers and also caregivers, I would think that the population would be quite broad that would be covered by that.
Thank you very much, Laurie. Well, we're nearly at the end of our time, so I want to thank our presenters once again, Erin, Laurie, and Brian, for participating in this, and I want to thank all of you, our viewers and listeners, for taking the time as well. Fasken has an incredible amount of resources available about COVID-19, covering all aspects of your business. Please do feel free to go to our website, to the COVID-19 Resource Center, and you'll see dozens of bulletins and other videos and webinars that are available to support you at this time. So thank you again, everyone. Please enjoy the rest of your afternoon and stay safe. Thank you.